So I know that other disciplines are talking about some of the environmental toxins that can affect the neuromuscular junction. Um, I just wanted to quickly summarize that the venom of snakes and cobras, bungarotoxin, can inhibit the neuromuscular junction very much like the curare type molecules. Latrotoxin, which is the venom of the black widow spider, also has an effect on neurotransmitters, particularly acetylcholine, from both kind of sensory and motor neurons. And that depolarization blockade kind of mimics the effects of succinylcholine. And then tick venoms have the ability to alter the fusion of acetylcholine vesicles and kind of preventing the release. And so there's a kind of a reduction or devoid activity of acetylcholine within that synapse. And just to kind of summarize all of these different targets within the neuromuscular junction, I really like this diagram, and I wanted to give it to you because there's just a lot of physiology and pharmacology here. And obviously, we didn't go through all of these different targets. Some of these are going to be saved for other cases coming up in the next several months. But I really like kind of how it correlates the anatomy of the motor end plate with the physiology and then the pharmacology in terms of the toxins and chemicals that exist within the environment that reduce or alter these specific effects. There was one correlate too about malignant hyperthermia, and I know that in terms of the physiology and the pathophysiology, you understand how this mechanism occurs, but I wanted to talk about why it occurs. And so several drugs are capable of actually inducing or causing malignant hyperthermia. And the two kind of profound drug classes that have this ability include the volatile anesthetics, which we haven't talked about because we haven't done a surgical case yet, halothane, and then these fluorine type molecules, all of which are derived from sevoflurane. And then the depolarizing muscle relaxants, succinylmethonium and decamethonium, have the ability to cause malignant hyperthermia. Okay, but there's one drug in particular that's been shown to be quite effective for treating malignant hyperthermia. And so now you know some of the iatrogenic causes of malignant hyperthermia. Now we can actually treat it. And so this is kind of our little segue into the treatment of this condition. We're looking at dantrolene, which is really a muscle relaxant. It's a chemical derivative of phenytoin, which is a anti-epileptic drug and a sodium channel type blocking drug. But dantrolene doesn't have these characteristics. It binds to the ryanodine receptor, specifically the RYR1 receptor, and basically prevents that receptor from opening the channel, thereby inhibiting the release of calcium. And so it's kind of sequestering calcium within the sarcoplasmic reticulum, and it has a kind of a more profound effect on the fast muscle fibers compared to the slow muscle fibers, but there's an effect on both. The only main thing to be aware of is that patients that have liver failure, hepatitis, cirrhosis, they have to get either a much reduced dose or maybe they won't even be able to take this drug because there's a biotransformation component to dantrolene. And so this is just kind of a little quick summary of malignant hyperthermia and the environmental interactions of the neuromuscular junction and some poisons and stuff that can be encountered in nature. So if there's any questions on this, please let me know, and good luck for the rest of the term.